All right, welcome back, guys, to the Daru Strong podcast. Today we have Dr. Tom Walters. He stopped by, also gave me this book, Rehab Science. Now, this is an encyclopedia of rehabilitation. So for coaches, for clinicians, this is something that you want to have. We talked a lot about rehabbing. We also talked about social media. He has a great YouTube following, a great Instagram following. He's been able to utilize his strengths and his abilities and his knowledge to improve the lives of others with rehab and physical performance. So I know you're gonna like this. Go ahead, check it out. If you're listening on Spotify and iTunes, give us a rating and also share it with your friends so that we can showcase all of the great content that we're producing here with all of the great guests that I have for you. And we're gonna continue on. So without further ado, let's get on to the podcast.
Let's go. Mind over matter. Put your mind somewhere else and keep going. That little voice in your head is trying to stop you from getting to where you want to be. Be successful and keep moving forward. With your host and world-renowned strength and conditioning coach, Phil Daru.
All right, so we're here. Dr. Tom Walters, Rehab Science. It's like the encyclopedia of rehab and physical therapy. I've been gracious enough to receive the book and I went through it, and now I'm gonna keep that going. It's almost like I have to revisit each section, right? It's like, okay, what's wrong with me today? Let me go look at it, right? Well, let's start off. How did you start, being a clinician, physical therapist, and why did you decide to take this route?
Yeah, first off, man, just thanks for having me. It's awesome to be here. I've been following you for a while. It's it's amazing when you actually get to talk to somebody in person and actually meet. But yeah, dude, I was an athlete growing up. I was in martial arts and gymnastics, taekwondo gymnastics, and I had surgery when I was in high school. I had knee surgery, and it was back in the day when they put you in a brace and immobilized you for a long period of time. And so I got this contracture in my knee. I couldn't bend my knee past 90 degrees. My quads atrophied way down. And I, because of that, ended up going to PT. And it was kind of my first experience with it. Before that, I think I was like a lot of high school boys. I just thought of exercise for getting bigger muscles and performance stuff. Sure. So that was kind of my first experience with exercise for rehabilitation and for pain and injury. And I basically I studied exercise science in college and then went to PT school and finished that back in 2007. It's crazy because I've been a PT for 16 years now. It's the time flies by, but it was always focused in orthopedics and rehab and the most common injuries that most humans have, adults have, all that kind of common stuff. And I was telling you before, I was in kind of a full-time regular PT for a couple of years, and I started getting bored of that, so I started looking for other things, and so I went and taught for a while and had some other kind of cool, interesting jobs. But
did you teach in school, or was this more like seminars?
I taught at a university. I taught at a college, so it was an undergraduate college. I taught in their kinesiology program, so I taught biomechanics. I developed a therapeutic exercise class and a pain science class. I taught that stuff to all these kinesiology majors, which was awesome for them because most of them were thinking about going to physical therapy school, 80%. So they liked having somebody who was in the field and had actually been working with people. Because there's a lot of academics that don't do that.
Exactly. We were just talking about that off air. That's
exactly. Yeah. So, but while I was there teaching, when I was in that teaching job, I had just hit the 10-year point of being a physical therapist, and I decided I had a buddy tell me I should start doing stuff on social media. And so I just decided I was going to start putting stuff out and just put something out every day that basically answered one of these common questions that people came into PT with, or provided something of value that was oh, you've got this problem, here's 5 or 6 exercises you could try. And I just started doing that. I was just I'm just going to do this every day. And it was really just a hobby. I was doing it in between. I'd teach a class. The academic environment's not full-time like other full-time jobs. You know what I mean? You'd have a break. So I'd do a post and respond to comments and things like that. And it just grew over time and got to where I have a book, which is crazy.
Yeah, it is crazy, and it is not just a book. It's like I said, it's like an encyclopedia. Honestly, I think it should be more money, but you're doing us a service here.
Raise the price.
I appreciate that, man. Listen, so what happened to your knee? What was the issue?
I actually was born with my kneecap in 2 pieces. It's called a bipartite patella. It just developed that way. So I had this little floating chunk that was out on the side. So it was right in my patellar tendon. So anytime I land from a jump or something, it hurt, my knee would buckle.
Wow.
So they just took that piece out. So it
You
wasn't
could feel it? You could feel the separation?
No, it's weird. It feels like my knee cap feels like the other side. So
Okay.
it must have been a really small piece of bone fragment. But the nice thing about it is there's no reconstruction. It's not like an ACL like you had, So it's, I pretty much just had to let it heal and then just re-strengthen. But the bummer was I was in that brace and my knee got stuck and, but yeah, I just took that piece out, and once it got strong again, I pretty much went back to.
Did you play sports at all?
Yeah, I was doing, I was pretty much full-time Taekwondo as my main sport. I graduated from high school in 2000. That's the year Taekwondo became an Olympic sport. So I was really heavy into sport Taekwondo and thought about, I didn't like high school. I thought I'd open a Taekwondo school and train for the Olympics and not go to college.
That's cool.
So that was, I just decided I'll give college a try for a year, and I got into anatomy and physiology. I just had never taken a class like that and sort of became obsessive, and that took me to.
When you were in school, the end goal was to become a PT? Was that one of the things?
I mean, it was on my radar because of that experience, but I wasn't really, I just knew I liked exercise science, I liked training. Gotcha. And I didn't really know, I looked at a lot of different things, like other medical careers, like strength and conditioning. I looked at a lot, but PT just for it checked a lot of boxes, so, I wasn't gonna, it's like medical school, people are in school till they're, it's so much of your life. I didn't want to go that length.
That's true.
I wanted to be mostly in the musculoskeletal system, so rehab was just PT was the right fit.
All right, so you go to PT school, right?
Yep.
What was the most difficult thing that you had to learn? What didn't come naturally to you as a PT or learning about being a PT?
I think the hardest thing in PT school is neuroanatomy. Neuroanatomy. Neuroanatomy and just physiology in general. I remember that stuff was so much like a foreign language, like the names of structures, identifying things on little sections of brain, like identifying like the red nuclei or something. Like the stuff was just really hard. I remember you'd read paragraphs in the neurophysiology textbook and you'd literally just have to read it over and over and over again. It was like you were learning a foreign language just by reading it a bunch of times. It was that was probably the most challenging. A lot of the stuff in PT school by itself isn't really hard. It's just the volume of stuff they give you.
Gotcha.
It's just so much information that's the part that.
How long does it last? How long is it? 2 years or 3 years?
PT school, most programs are 3 years. So you do your undergrad, you have to have a bachelor's degree, and then it's a 3-year DPT.
Gotcha. So when you were hands-on with a lot of the things, or was it more just by the book?
It's probably about half hands-on, half like pure textbook work. I mean, the schools vary, but ours, it was like the first year was all academic stuff, and then you'd start alternating between like a semester in the classroom, a semester out on like an affiliation.
Gotcha. And
you'd gradually over time ramp up in how many patients you were seeing. So in the beginning, you're just watching some other PT, do evaluations and treat people, and then in those longer, like you'd have these 12 to 16 week affiliations, you'd kind of start by seeing like, maybe you're seeing 10% of the patients. By the end, you're seeing 100% of the caseload, and the PT's watching you.
Yeah, gotcha. When you first started being a practitioner now, like what was the main thing that you saw people complaining about or having injuries on?
Yeah, I would say, this is kind of like when I was thinking about the book, this is kind of what I was like, I ended up doing 50 conditions, but really there's probably 10 to 15 that are like the main ones that most people come to PT for. Of course, it's the stuff you hear a lot about, like lots of low back pain type stuff. Like
sure.
We call it non-specific low back pain. It just basically means back pain that can't be attributed to anything like a tissue structure for sure. It just it hurts, and you might have an MRI and there's nothing there.
Gotcha.
But it hurts. So back pain, neck pain, of course, nerve pains that radiate from those areas, like whether it's like a sciatica or somebody's got something that goes into their arm, people down the tricep, into their carpal tunnel. And then, when you get out like into the extremities, there's a lot of, like we were just talking about out here, but like, tendon type pains, like tennis elbow, golfer's elbow, like plantar fasciitis kind of even falls in that. Like a lot of these connective tissue problems. IT band syndrome is a connective tissue problem. Yep. All the tendinopathies, patellar tendon, Achilles tendon, rotator cuff tendons. Like, dude, honestly, like most of the things I see in the regular kind of population of active people are tendon problems.
Is that through faulty movement patterns with high repetition?
Yeah, it's usually not even necessarily faulty movement patterns. I mean, it could be if it's it's often something new, or it's something they've been doing, they just ramped up the volume of it.
Gotcha.
So like it could be somebody that is just went on a trip and like did way more walking than normal, and it flared up their plantar fascia, or they, you know, are like a thrower, or maybe they used to be a thrower or some kind of throwing sport, and they don't do that anymore, and now they go and start throwing again, and their rotator cuff tendon gets flared up, or they're a jumper, or used to do a lot of jumping, and now they start getting back into it, and their patellar tendon, you know, they ramp up their running, like it's all that stuff. It's usually like volume goes up, and then their tendons start hurting.
So I had some nerve damage or nerve pain, right? I have some pinched nerves. I got C5 through C7. We talked about it. What are these nerve glides? Like, what do they actually do? Because sometimes I'll do them and I'm like, I don't think this is doing anything.
Yeah, totally. Yeah, I think a lot of people always joke when I do those in videos, like, oh, those are some cool dance moves. You know? But nerve glides are kind of cool. They a lot of times people will hear about them. It's called nerve flossing exercises. We call them nerve mobilizations. There's a bunch of different terms, but basically the way they studied these was they take pins and put them in the nerves and cadavers, and then they would move the cadaver's arm or leg, and you could see the nerves had to slide, and it could be anywhere from certain nerves be just a few millimeters, some could be a couple of centimeters. You know, so it was like nerves are said to have, they're like spaghetti noodles, they're kind of like a spaghetti noodle. When you look at them in a cadaver, they really will kind of slide through almost like these, not tunnels, but they're in between like fascia and muscles, and they'll slide in that kind of space. So those nerve mobilizations are meant, they usually don't feel like much when you're doing nerve flossing, because you're meant to be not really ever putting a lot of stress on the nerve. You're kind of pulling it one direction and then the other, so it's never like it's being stretched, or you don't really feel much because you're just getting it to slide.
Gotcha.
More recent studies have shown that when you do that, it actually helps improve blood flow. Your nerves have their own microcirculation, so if they've shown this in the carpal tunnel, that when people do these different nerve mobilizations, it actually increases blood flow into them.
You did one where it was like the fingers, right?
Yeah, that's like this new one where you go, is that the one you're talking about?
I think you were doing this or something.
Oh yeah, that's a different, that was another like probably trigger finger or something, like another.
Yeah, now it's good for our tactical guys.
Totally. Yeah, it actually probably helps with nerves too, but like that carpal tunnel one, that's another big, you know, disorder a lot of people have. That involves your median nerve running through, and you know, so they've got these mobilizations where you can kind of move your head and arm and get
I do this, and I'll like for the, I think it's for my ulnar nerve, and I'll come here, and then I'll bring it back in, and I come out. It does help, I mean, to a degree. Like I think that me just moving my body, like it feels better. For sure. But if I go to a certain point, it's painful. So I have to stay out of that.
Yeah, you're putting stress on that nerve, and that's so true, because honestly, for nerves, it's just about moving, because if you just move like your extremity, it moves the nerve, and then that helps the blood flow. Like sometimes I'll have people where they can't, the nerve mobilizations actually make them feel worse, and they'll just do things like you lay on a foam roller and do like a snow angel, you know, and just like doing that. I mean, I had a lady one time tell me that doing Tai Chi was the best thing for her nerve pain, because I think just the movement she was doing, they weren't, like when I gave her the nerve exercises, those were too specific and they'd flare her up.
Gotcha.
So it's a lot of times it's just keeping the area moving, but yeah, they're not, you get different responses. Some people do the nerve stuff and they really feel a lot better. Some people will just have kind of a minor, it'll help their symptoms a little bit, but you know, it's not always like this magic fix.
Well, there's a section in the book for pain, right? And I think that's the one thing that I go back to all the time. Because it's psychological in a lot of ways too, as well as along with physical. What is pain?
Yeah, pain, so if you look at the most kind of up-to-date definition, which comes from the International Association for the Study of Pain, they basically talk about it as being this unpleasant experience that has both social or sensory and emotional components. And I think the key part, you know, so sensory and emotional, like that's key to focus on, and then they'll say associated with actual or potential tissue damage. And I think that's a big part for people to think about, because most people think when I'm in pain I have actual tissue damage, like something in my body is hurt, like I hurt a muscle or I hurt a tendon or a ligament or something. But it's really important to know that pain can be from potential tissue damage. So if you believe something is going to hurt you and damage you, your brain can create pain to protect you. And they have cool studies out there where they do this to people, where they basically convince them that they're going to hurt them, and the person will have a pain experience even though nothing actually happens to them.
Is that like a reaction or a response, like an efferent signaling thing going on? Like if I touch the hot stove, right? It's automatically going to pull me back. Like it feels like a sharp or I should say a sudden pain receptor or whatever is going on there.
Yeah.
But if you keep it on there, you could burn yourself.
For sure.
Right.
Yeah, they so now we used to talk about, oh, you'd have these pain receptors and something would happen and you'd activate a pain receptor and that'd go up and tell your brain, hey, there's pain there, you gotta do something about this. Now they're finding that pain actually is outputted by your brain 100% of the time, and really in your tissues you have nociceptors.
Yep.
Which are these danger, right? It literally means like a danger receptor.
Yeah.
So they just basically detect noxious stimuli, like stimuli that could potentially damage you, and they take a stronger stimulus to turn on. So like normal touch nerve endings and stuff, right? Those turn on really easily with low stimulus. A nociceptor, you have to put in a stronger stimulus to hit its activation point. But then when that activates, it basically sends that up to your spinal cord and up to your brain and tells your brain, hey, there's some danger here. And then your brain, that's where like that psychological stuff comes in. Your brain is gonna look at everything. Not just that sensory input, but like, hey, have I been here before? What kind of memories do you have about the situation? What does this whole situation mean to me? Okay. How am I feeling? Like, am I stressed out right now?
Yeah.
So all those factors are going to come in. Then your brain's going to decide. Pain is just one output. Like, so your brain can send pain down to that area. Movement is another output, right? Your body could just decide to move and not create pain. You can have stress responses. So it's way more complex than we used to think of it. You know what I mean?
And I have this theory, right? Like we were talking about isometrics, right? When something's painful, like my knee, for example, after the surgery, we'd use isometrics. Can we down-regulate nociception through isometrics? Yeah,
you can. You can down-regulate nociception. You kind of can think of it as almost like a dimmer switch. There are different neurotransmitters and different molecules that your brain, like literally they talk about now. I don't think people realize this, that like our brain can basically make morphine, and it's called the endogenous opioid system. So our brain literally produces opioids. So if you need, like, say you have those nociceptive danger messages coming from your tissue up your spinal cord, there are a lot of times where your brain will be like, this is not a good time to have nociception, and can output opioids. Make opioids. I mean, they call it, we basically have our own drug cabinet in our brain, and I think people just think about opioids, you go get a prescription, you get opioids, but your brain literally makes opioids, and if your brain decides that, like that nociception is not useful or not helpful in this moment, it can dump some of those things and basically, like a dimmer switch, kind of turn that nociception down.
Wow.
When you get into like isometrics and the mechanisms through which they work, it gets really complicated, and there are people who, I don't know that I would speak to it fully accurately. Like there are literally people now who do PhDs only in tendon science, like tendon rehabilitation. Like just they spend their whole career, their whole PhD studying tendons and how like an isometric might modulate pain.
That's interesting. To like really pinpoint out just that one particular aspect.
Exactly.
Are they going, those are the people that are obviously going to be physical therapists or some type of clinician, correct?
They're physical therapists first.
Yeah.
So like they'll get their doctorate in PT, which is more of like, it's like a clinical degree. You're not usually doing a lot of research.
Like a general practitioner?
Exactly.
Yep.
And then they'll go do a research doctorate and just focus only in the science of tendons or whatever. Or
specialize in it. Yeah. And then you're like, that's the guy you go to when your elbows are flared up.
Totally. Yeah, there's cool research coming out on that stuff. Like I said, I see so many tendon issues, especially in active people. So all the tendon studies are actually pretty interesting. Like you said, isometrics really have quite a bit of research for helping to reduce tendon pain, where you're just taking a weight and just holding it and challenging that tendon. You're not doing any movement, and it almost has this like hypoalgesic effect, almost like if you took ibuprofen.
Yeah.
Crazy.
You're big now on social media. Right, and I think I found you, I think I saw a reel pop up, and then I started following, you followed me, which was cool. I was like, oh, cool, back and forth. But when did you start really putting it out there, like really doing it? Because there's a lot of coaches, there's a lot of clinicians out there that don't want to do that or don't need or feel the need to do that, and to each his own. But how important is it for you to put out that content like that?
It's huge. I mean, I actually, this current account I have going, I started in right at the end of 2016.
Yeah.
But I'd actually started it twice before and deleted it. And I think I realized those previous versions, I would put stuff up that was just kind of personal. Like I'd do box jumps at the gym and put up a video, and that didn't help anyone. It was just, so I think I realized, I remember I went to class one day. I've told this story before, but I went to class and I had just deleted that account. And a student came up to me and said, hey, my mom has this rotator cuff injury and you had some exercises and they were really helping her, but I can't find it. And I had left class that day and I was like, holy crap, I need to do this every day and just make it like stuff that's just totally valuable and helps people with these problems. And so, I mean, that was a huge motivation. I just wanted to, like I said, I'd been a PT for like 10 years, so I had kind of the common patterns and common questions. I knew, I had that experience to like know what to address in posts. And there was also just a lot of BS. There was a lot of BS in rehab that drove me crazy. Like I'd have patients come in that had been told things that were just wrong, but practitioners were telling it to them either to make them dependent on their care, like, you got to keep coming back so I can align your spine or else you're always going to have this pain, or like, you've got this leg length issue.
I was going to ask you, what are those main things? Because there is a lot there, and I see that a lot of chiropractors are like that too as well.
And dude, and I have friends who are chiropractors.
Yeah,
there are a lot of good friends. There are a lot of great chiropractors. There's good and bad of everything. But I think, unfortunately, for whatever reason, there's people in that profession that come from certain schools of thought, and I think they are trained that doing these techniques put something back into place, but there's just not really any evidence to support that. And I think the problem with it is that, say you go in, you have back pain, and they do an x-ray and they say, oh, this vertebrae is out of place. So I'm gonna manipulate it, I'm gonna adjust you, and I'm gonna put that vertebrae back in place, and we're gonna change the kind of curvature of your spine, and that's gonna help get rid of your pain. The thing is that, the evidence, when you look at it now, when those interventions are done, it doesn't actually, you can't show that something's actually has moved and been put back in place. And you have situations where, if you look, this is where pain gets complex, where somebody might have that intervention done and their spine looks exactly the same, but now their pain's better. Or, their pain doesn't get better at all, and nothing changes with the image. There's basically just been so much research now on these things, kind of debunking them, that you can, even as a practitioner, find these asymmetries. I was trained this way in the beginning, that I would have someone lay on a table, I'd look at their pelvis and I'd be like, oh, you have an anterior, you've got an anterior rotation on this side, a posterior rotation, or up slip, down slip, or your leg length is off. And now they've done these studies where they'll take people who literally are expert practitioners who have like 30 years of experience. They'll bring patients in and not tell them what their problem is. And they'll say, just analyze their pelvis and tell us your findings. Completely unreliable. Like the practitioners never match up. And so your eyes, there's all kinds of illusions when you look at people, you can look at them and
even if they're lying down or standing, they're walking, there's so many different...
Their clothes could be off a little bit and you think their pelvis is off. And they've, also they found that people's, like if you look at the pelvis, people have anatomical asymmetries, like their bone, like your ASIS, the bony spot that sticks on the front could be different from side to side. So you could look at that as a practitioner and say, oh, well, you have an anterior rotation, your pelvis is off, and base your treatment on that, when really it's just some bony change that they developed with. So there's just a lot of myths kind of out there, and I think what frustrated, so not only did I want to put out stuff that helped people, but I also was frustrated by some of these narratives that were harmful to people. It's the opposite of placebo. It's like, it's a nocebo. So you're literally hurting people by putting this thought virus into their mind that isn't true at all. So I wanted to kind of push back against that stuff.
Yeah, they're making them more, what was it, the word I'm looking for, they're just making them more anxiety driven.
For sure.
Based off of things that aren't really even there.
Exactly.
What do you think about PRI? You ever heard of that?
Yeah, postural restoration. I don't know a ton. Their stuff comes up from time to time.
Because I was talking about like pelvic alignment.
Yes,
you know,
they're very posture focused.
Posture focused, breathing focused.
Totally.
You know, diaphragm, stacking diaphragm or stacking the rib cage over the pelvis. I do agree with that in some capacity, because there is a lot of people that, especially in my world with fighting, we're so asymmetrical, right? And everybody isn't symmetrical in nature, but when we look at fighters in general, especially being in that bladed stance, they're so asymmetrical. But there is a fine line between, you know, getting them in the proper position to make sure that they're balanced, but not taking away from their skill and their ability to move in that position, right? So like when I look at something like a PRI, or like even stuff like with Stuart McGill, and working through the diaphragm, and everybody has their own thoughts on it. What do you say is something that you would think of, like, what's the overall? What do we want to focus on? If, like, for me, for instance, if I'm looking at an athlete and they come in, what should I be focusing on overall?
Well, I think you know, those types of models, you know, where they're like maybe posture heavy, because I was like that in the beginning. I mean, when I came out of PT school, I was it was called the PSB model. It's postural, structural, biomechanical. Like we looked at all pain and injury through that lens. And the thing is that, that does help a lot of people, but there are some people who don't get better. And I think when you look at, like, if you look at those systems that are very posture heavy, a lot of times those interventions, like the exercises and things you might do, actually help a lot of people. More now, it's like the mechanism through which it works is thought to be different. You know, like if somebody's pain gets better, maybe it's not because you like fix them into like the correct position. It's just that you introduce some novel stimulus to their nervous system or something. Like it just, the complexity of like kind of the neuroscience of pain has just changed, and really it almost makes you feel like there's more uncertainty. Like you don't always know why something's working. But I think at the end of the day, like no matter, you know, who you're working with, obviously it's going to vary a little bit, quite a bit, like with their demands, you know. So I think to me, a lot of it nowadays is thinking about what are the like mobility and flexibility demands that this person needs for the tasks associated with their sport. Like we were talking about hip mobility earlier. You know, like I knew Taekwondo hip mobility was huge. I needed a ton of hip mobility to kick people and stuff. And so, you know, in a sport like that, you know, I think looking at people and assessing mobility in those joints that are relevant to their sport is a huge thing, and kind of knowing how much can you play with that and it helps them versus interfere with their performance. Because we used to see this with like baseball pitchers, right? Baseball pitchers have a ton of shoulder external rotation, and they often have very little internal. And for a while in the PT world, we used to think, well, we've got these textbook normals, like, oh, you should have 70 degrees of internal rotation, you should have 90 to 100 degrees of external. And we'd look at these baseball pitchers, and they'd only have like maybe 5 or 10 degrees of internal, and all the PTs back then would say, oh, we need to stretch that. We need to normalize their internal rotation because it's way below what's normal. And then when you did that, they threw the ball slower. So their performance went down. It turned out that
it's tighter, less tight,
like they actually had adapted that in some cases their, like the bone had actually twisted from all those years of throwing. Like
I believe that. You ever slow down a pitcher?
It's crazy.
It's like all the way back here.
Totally.
It's disgusting.
So I think, you know, you have to think about, for me first, kind of think about mobility. Do you have the mobility that you need for the tasks? And then really most of like good PT these days is resistance training focused. Like, because if you think about the musculoskeletal system, it's more likely to be injured when its capacity is lower. Like, which when I say capacity, I mean how much load can it tolerate. So you can think about like just in biomechanics, like how much force can your system take, and does it, the more force that system can handle, the less likely a tendon is to rupture or a ligament's gonna tear. I mean, of course there's accidents, like things happen, but you're less likely. We know with resistance training, your tendons get stronger, of course your muscles, like your bone density goes up. All these things, when you look at research for injuries, resistance training by far has the best evidence for reducing the risk of injuries.
There you have it. Enough said, we could drop the mic now. No, because I get into I don't get into arguments, but we do get in some debates, and I talk to boxers, and you know, with the I guess the negative connotation or that stigma behind lifting weights. And I don't know why it's still there, but most old school coaches will still think that they were doing bodybuilding techniques and we're just focusing on hypertrophy training, and because that's what they've seen in the past. And the goal really is to reduce the risk of injury, you know, based on one, it's a highly contact sport. It's like highly collision-based sport. And so we're trying to build up the structural integrity, we're trying to build up the stability and the strength in the soft tissue so that they can like absorb that load and force, and they can produce that force.
For sure. No, I totally agree with you. Even if it's bodybuilding type workouts, like if you had regular bodybuilding splits, it would help boxers. Like it would just strengthen those tissues, like their muscles and tendons around their shoulder, their elbow we were talking about earlier, like that stuff is going to, of course, like they would have explosive things too, like, but they would be doing that in their training with their sport, but you know, they'd have that heavy, slow kind of stuff that builds up tissue capacity, and then you'd have other power-based things that train the, because right, like what, if you look like tendons or something, right, like they need to act like a spring, they need to be able to store and release energy quickly. So if you only do slow, heavy lifting all the time, you're not going to train that capacity of the tendon. So we kind of look at like this ladder progression of how you train tissues, and you know, it's like that whole, it's the SAID principle, right, like what are the demands of their sport, and are you, but I just think every athlete, we have so much research on it, there's a place for strength training.
I mean, they're humans before they're athletes. And every human should do weight resistance training. Again, and there should be a level of, you know, training based upon that force velocity curve. Like you need high force, but you also need reactive strength, you need explosive strength, you need speed from performance standpoint, but also as a human, right? So like when we talked about with tendons and ligaments, and like if you only train that, and then you try to do something that's explosive, that you have to use your muscle, you may tear a muscle.
Dude, that's why you hear about so many dads like tearing their hamstrings. That's right, they don't ever sprint anymore. They might go to the gym and lift, but then they got to chase their kid or something, and poof, they pop their hamstring.
And, okay, so this is a good one. So what do they need to train so that that doesn't happen?
Well, they need to, I think, first have that foundation of slow strength. Right, like just regular strength training, like have that foundation of kind of the pyramid, and then after that, to me, it's honestly incorporating power-based movements. Just as a human, like you should have that. You should be doing stuff like box jumps and sprinting, and you know, I mean, if you want to be able to throw with your like kids or whatever you have going on in life, and you should practice doing things that are make your tissue store energy and release it rapidly. You know, and you should practice those things. I know during COVID, because the gym shut down, I've always been really big into jumping. I just enjoy training that. But I noticed, I didn't even think about it, but I stopped training jumping because I just didn't have plyo boxes at my house. Dude, I was just doing squats. I was doing all my normal slow stuff. As soon as I went back, I got a bad patellar tendinopathy in both sides. But I realized that I had basically taken that stuff out of my program, and it didn't take many months of that being out of my program to where I lost that capacity. And then when I tried to reintroduce it, I had a problem. So I also strained my hamstring. You know, I went back to sprinting. I was running up a hill. Now, so I ended up having a hamstring tendinopathy up at where it attaches on the pelvis, and strained my hamstring. But it was all stuff because I basically kind of lost that function because I stopped training it. And I think and you know, that stuff goes for all ages. We even see in elderly people that if you train them in power, quick movements, they're less likely to have falls. Because if you think about, if you trip, like we all take it for granted when you're young. If you
lose
trip,
that reactive quality.
You need to be able to generate force rapidly. Like if you trip, you got to generate force rapidly so you don't fall down. Older people who don't train that, they will try to catch themselves and just break their hip and just fall.
What's a good reason behind doing hypertrophy training?
Well, I think hypertrophy training is going to have, I think in rehab, we're mostly thinking about strength, like how strong are you? But of course, I think you look at this research now on, remember how we used to always think about, like, if you did this many reps, it was strength, this many reps is hypertrophy. That's gone kind of out the window, right?
It is out the window,
So I think, to me, if you're doing hypertrophy training, you're naturally increasing strength. And going along with that, you're going to increase the strength of tendons, muscles, all those tissues, besides them getting larger. I think I'm probably, as a rehab person, less worried about the size of it, but just like how much force can it handle. I mean, for me, it's different. Depends upon, like, okay, if we're building this person up to go to a different weight class or higher weight class, then we want to put on the muscle that is going to be conducive for them to not only be able to obviously get to that weight class, but to not hinder their movement quality. And I think another thing that I've seen just off of fighters alone and just general people is that they lack mobility, right? And
you can even have phenomenal flexibility in passive end range, but they can't control it in those end ranges and be strong in those end ranges. So that's why like I got into doing like FRC and doing a lot of that stuff. And what I did find was that it was a missing link in our ability to progress our athletes. And so for that, I went hard on mobility, but we did it in the form of strength training. Right? Because it is isometric contractions a lot of times, or it's overloaded eccentrics or super maximal eccentrics. You put somebody underneath the bar and they can't get into a full squat. If you get that bar heavy enough, they're gonna get into that full squat. And you know, obviously you have to put them in the right positions from a base standpoint. But if you cue them in the right way, they'll squat the way. You know what's so funny? And you can correct me if I'm wrong. Whenever I look at an athlete, like you do your basic FMS or something like that, and it's like with a dowel or some shit like that, and you go, I can correct them. Like we can look at like, okay, oh, his posture's off, maybe they're misaligned here, or you know, they got a navicular drop or something like that. But if I just cue them onto like screw the feet into the ground and like produce laterally push your legs out, or like what we call spread the floor apart, it fixes a lot of that.
Dude, most stuff is like that. Honestly, like most postural stuff is motor control. Like if you just teach, most people aren't even aware that like, and if you cue them to use their neuromuscular system, you teach them like navicular drop. Like somebody's got a navicular drop and you're measuring that. And if you go and just teach somebody, like we use this doming exercise a lot in PT, where it's like you literally you teach the person to use the deep intrinsic muscles of their foot to lift their arch. Like, and once people short foot. Once they know that, they don't have navicular drop anymore, as long as they're actively thinking about it. I mean, I think the thing that's interesting about exercise, there's a lot of people who think, this is the other thing that's interesting about the posture stuff. Like, a lot of people had this, used to think for a long time that if you did certain kind of corrective exercises, it would permanently change your posture. And it seems like that isn't really the case. Like there's a lot of shoulder blade and shoulder studies where the person might get better in a lot of ways. Like they'll perform better, their pain might get better, but their actual like static posture won't change a lot. Dynamic posture changes, like they know how to control it way better. And I think that's kind of like when that's a lot of times when I talk to people about not caring about posture as much, it's static posture. Like I don't really care a whole lot about, like if you want to slouch and that feels good to you, I don't really care. Like as long as you dynamically can move through full range of motion, like you said, as long as you have the active mobility to take your joints through full range of motion and control them dynamically, I care way more about that than what you look like just sitting still.
Man, so this is interesting because I work with Timbaland, the record producer, and like, you know, him being a record producer and being overweight his whole life primarily. He was like super kyphotic, hips roll off, and he would just stay like this all the time. And like even, when he was walking, when he was sitting, whatever, right? And we took a full year, almost a year and a half, and I was just getting his posture to be set in static and dynamic. Increasing range of motion, like soft tissue work and mobility training and all that stuff. And getting him to breathe diaphragmatically, trying to get all of it worked on, and it takes like so much time. It really takes a lot of time.
Sure.
And like I said, a year and a half. And finally now he's getting to the point where he does have that dynamic movement to get into, like you said, dynamic posture, right? He has that, but then I always see he'll go back to like a safe space, which is like his default. And I'll be like, man, posture up, but he gets into it, and before he couldn't, and he sees it too, which helps with everything. But do you think that like if they do go back to that, is that going to be kind of counterproductive for us doing our dynamic posture work?
Yeah, I mean, potentially. I think that's where like the biomechanics and neuroscience stuff is kind of interesting, like how that meshes together. Because I think, like his example, if he had been like that for years and years, you could imagine like his connective tissues had probably adapted to that. Like he probably, I mean, that's probably why it took you guys so long working on it. He probably had lost some mobility for like extension in his thoracic spine. So you couldn't just say to him like, hey, like he's probably not the person where you could just give him motor control exercise and he just like learn it. Like you have to get the mobility, like he almost needed the passive mobility first. You had to get his connective tissues to be more mobile and flexible, and then teach his nervous system how to control that. I mean, I think if he falls out of that and goes back to his default, if he were to not have you and not think about that stuff, I'm sure to some degree over time, his connective tissues would adapt to that. Because that's the thing about the musculoskeletal system, right? Is it's always adapting.
Yeah.
Both positive and negative. I think.
Sure.
I think a lot of times, at least for me, and I'm sure you're the same, I'm talking to a lot of people about the positive adaptations, like the fact that everything can get stronger and you have neuroplasticity and all these cool things. But
Yep.
I think there's obviously the negatives too of like being sedentary and not using your full range of motion. Like over time, that's going to, things atrophy and become deconditioned, and probably to some degree, joints. We know joints can develop contractures, and probably at the beginning of that spectrum is just you lose mobility, right? Right? Maybe if he didn't keep working those things and just went back to being kind of rounded, maybe he would lose some of that. His thoracic spine would actually become hypomobile, and he'd lose some of that.
Sure.
Just connective tissue, kind of its ability to become extensible.
Well, I think I see that a lot with the fighters too. Like they go back to those fixed positions.
Yeah.
And it's a constant, it works there, right then and there. Like if we do a basic 90-90 pales and rails contraction, right? Where we're working through those antagonistic muscles, trying to gain that range. And then, they feel good. Their hips are great for that hour, maybe 2 hours after, but then then they don't do it anymore, and then they go back to it, and then next week they're like back to where they started. So I think it does come down to frequency too, correct?
For sure. Yeah. There's a guy that I follow who does all stretching research, and he it's interesting to look at these studies because, I don't know, did you ever try to get the splits when you were
I did.
younger? Yeah.
When I was 4.
Yeah.
For karate.
Dude, you got the splits.
I was in there.
I could do the splits.
Can't do that shit no more.
Yeah, no, mine's gone too. Yeah. But dude, I was in high school. I could do the splits across chairs, like Van Damme style, sit on chairs.
Yeah.
And I remember when I taught Taekwondo, you'd have people come in. It was always so interesting because each person was a new case study, right? They'd come in, and you had to get them flexible to be able to head kick and do stuff. But I think that was a cool example to me of how much you could change the joints and connective tissue with really consistent and longer duration stretching, and I feel like that's the stuff I'm probably seeing more and more in the research is how long you actually have to hold stretches for to keep mobility permanent.
Sure.
And it won't, it's probably gonna revert if you don't keep working it, but I think I don't have my splits anymore. I kind of slid back over time, but I think a lot of people, when they're doing mobility and flexibility work, they don't hold things long enough.
Yeah, well, it's boring. Let's be honest. Shit is boring, man. I think that's why a lot of people like doing yoga, because there's a mix of breathing, certain positions, and then you change positions. Yeah. It's a little bit more relaxing to some people, maybe not to others. Yeah. And then they got the hot yoga. Yep. But I think I never was a fan, and now knowing the body more in depth and working with a large amount of athletes, and me being an athlete myself, when I get into a position, I want to be able to at least contract the muscles that allow for that range to occur. So whatever muscle that's crossing the joint for whatever, a split or hip flexion, hip extension, I want to get into the end range and still be able to contract my glutes and hip extension. If I can't do that, then it's a faulty firing pattern or something like that, where I need to make sure that I have control there. I think when you're just passively stretching, you don't really realize that, or you don't think about it.
No, I think there's actually a lot of people who are like that, who have great passive flexibility, but they can't actually control it, and then your injury risk is higher with that kind of stuff. I agree with you, man. I think whatever passive mobility you have, you want to be able to contract and control that range of motion. I mean, you see it in young gymnasts, female gymnasts all the time, especially you'll have hypermobile gymnasts that can't control their joint through a particular range of motion, and the injury risk is higher because there's a window in that joint's mobility that they don't have any control over. And when you think about stability in your body, you've got your passive subsystem, you've got all the stuff you don't have voluntary control over, your ligaments, bones, things like that. But then you've got your active subsystem, your nerves and muscles, and I think you need to, if your passive subsystem can go through this huge passive kind of stretch mobility-wise, you want to make sure your neuromuscular system can also contract and control that whole range of motion. Otherwise, you're just, your risk of injury, I think, is higher.
What's the lag? Is there a degree of lag from your passive stretch to your active?
I think it varies by joint, but for most people there is. For most, you can take them to a passive endpoint and then ask them to hold that. And you know, I mean, of course, like some joints people totally can, but you know, some, I think the hip is a good example. Like a lot of people, you take them to passive end range hip motion, ask them to hold there, they probably drop 15 to 20, you know, probably 10 to 15 degrees.
That's
Let's
crazy.
fall from that position and can't hold it. And
what I'll do is like for my dynamic warm-ups now, just to get everything worked on, we'll go from a passive to an active, but we'll do it dynamically. So like the perfect stretch or the world's greatest stretch. Like I'll go knee pull, chest tall, and then go into an active and hold at that end range. Go into a lunge, same thing, kind of hold, squeeze the glute, you know, and then work all the way through the stretch. But like I found that, but what I found with the hips in general, because the hips are just so important for everything. The internal rotation and extension. It's hard to hold, no matter what. Like a lot, because they'll go into the low back. A lot of people just kind of get into that extension of the lumbar spine to try to get to that range.
Internal rotation's a hard one just by itself. Like internal rotation, when we measure that on people, that's probably the most restricted hip movement on most people. Like when I go to, because the textbooks will say you should have 45 external, 45 internal. Most people, especially males, hardly have any.
And why is that though?
You know, it's a good question. I think a lot of it is like adaptive shortening. You know, I mean, I think females, you know, naturally just often ligamentously are a little bit more lax and mobile. But you know, if you think, I mean, we're all doing this.
Is that like due to like muscle, or is that due to like maybe a predisposition because of childbirth? With the hips in general?
Totally. I mean, I think some of it is like the difference in anatomy from males to females, just like how the pelvis is set up. And for sure, like angulation of your acetabulum, like that socket can influence how much rotation you have. But, and I think probably people just don't use it. Like we were talking, like, I just think there's a lot of mobility that people just never use. And like, I mean, we all sit in external rotation all the time with our hips. Like our hip is used to that, the joints used to it, the soft tissues are used to it. Hardly ever are people like,
you know what? It makes sense because a lot of people are sitting all the time, and we naturally go into external rotation. When we get into
legs are out.
And then when you look at when I look at gait, you know, because a lot of my guys, man, like let's face it, a lot of fighters can't really run because they lack the mobility in the hips or the ankles or whatever, or they don't crush the ground with the big toe, or they have a navicular drop and they can't. You know what I mean? So like the whole gait is off. And you go, well, they try to run, and now they're running externally rotated. They can't internally rotate, you know, off like in a toe off or whatever. And then you go, well, that's why they have knee problems, and that's why they have back problems.
Yeah, it's interesting. Like athletes of different backgrounds, like they just have all these adaptations that happen. You know, so it's interesting. Like you hear those adaptations to a fighter, which those adaptations are probably helpful in certain aspects of like what they're doing.
For jiu-jitsu,
like
this is guard.
Totally, like all that, all the hip mobility for jiu-jitsu. Like I mean,
but they're good in external rotation. Some of them are terrible. Or let's say, for instance, they have a major asymmetry because they knee cut on one side, and their other side is like kind of searching for the hook. You know, so the external rotated
they're
on
on
one
external
side.
on that side all the time, and internal only that side can.
Because they'll fall more to one side of the hip because they'll play on that hip. You know?
Yeah, for sure. So it's like those natural kind of asymmetries that are like a part of their game, and then it's always, you know, but then you take like that person, you try to make them run, which is a totally different set of demands. I mean, I think it's interesting when you take anyone who's practiced one particular sport for a long time, and then you try to, you can just like you'd be such a great athlete in that area, and then you try to transfer, you just see that it doesn't a lot of times transfer over to something else that's totally different. Mobility demands totally different. Like you might be an athlete who doesn't need any ankle dorsiflexion, and then you try to go, you know, like then you.
It's hard though because like with boxers they probably don't, but when we try to put them in positions to get them stronger to activate the muscles that will help them, we can't because they lack the range. So like okay, a squat and a lunge are out of the question because you have shit ankle dorsiflexion.
You know? And I think you're right. You know, you were talking earlier about using resistance training to help gain mobility. You know, you see more of that stuff these days. Like, I mean, I think one example that helps a lot of people probably can, you know, kind of identify with is like tight hamstrings. Like a lot of people can't bend over and touch the floor right. I've got tight hamstrings, and you see more and more of this talk of like, okay, well, you can just sit there and stretch your hamstrings, which you've probably tried and it didn't help much and it didn't last that long, or maybe you think about like, maybe it's somebody who doesn't deadlift at all. And it's like you take that eccentric contraction and, you know, you work on mobility that way. Like you were talking earlier about the squat, like maybe somebody can't get all the way down to the bottom squat. Maybe it's because of limited ankle dorsiflexion, or maybe it's a knee flexion issue, or whatever it is.
Yeah.
You know, loading them up and making them do those eccentrics down to that position. Maybe that's a way to, you know, for some people that helps them gain that mobility where they're having to do that eccentric contraction. And
yeah, and then we have to revert to like a heel wedge and things like that, which is fine, but then like that's putting a lot of strain on the VMO when we may be wanting to hit more hips and hamstrings and sitting back into the squat. But we'll also use a box for that too as well. So there is ways to do it.
Okay. Yeah.
But then I'm like, well, yeah, so like I can always find a tool that will work with you and your body and your structure and what you have right now as active range. But do I want to improve on this? And this could be possibility, because what about running and jumping too as well? So if they lack range of motion in their hips because, you know, whatever factor of the sport, maybe they need it though to jump higher, you know, because they need more hip extension or something along like, because a lot of the guys don't have hip extension because they're like, I go back to the jiu-jitsu guys because they're always flexed.
They're always flexed.
Right? So like, but when I'm like, yo, we need to get more hip extension and posterior chain work, because one, that's going to alleviate stress on the low back, and then it's also going to allow them to get that triple extension for power.
Totally.
But if you're not getting full hip extension, then what are we doing?
Yeah, you know? Yeah, it's almost like, I'm sure this is what you're doing, it's like you have to have those things structured into their program, because if they only train the sport, like that jiu-jitsu person is not going to be doing a lot of hip extension. And then if they, you know, just as in terms of being a human who can move well, you'd like to have that. And like for those other kind of performance things, like you want to be able to jump, or maybe do sprinting as a part of your conditioning workouts, like you want to be able to move well in that too. So it's, I think, you know, in mobility work, it's, I think some of it, you know, like you think about ankle dorsiflexion, like I do wonder sometimes, like, can everybody, you know, you feel like sometimes you hit a ceiling with people, like how much mobility can their body really gain? And I think that is interesting, looking at kind of connective tissue and fascia, because you meet some people, like going back, I mean, I think back to those Taekwondo days, like we'd have some people who could, in a matter of months of consistent stretching, could really become flexible and control that, and some people just struggle, you know, it's like you just had that spectrum. And ankle dorsiflexion is one that comes up a lot on my account, because I'll show mobility exercises for it, both active and passive, and there are some people that like work at that stuff for, you know, just diligently work at it and have a really hard time gaining it. They can never do, they have the hardest time ever doing a squat where they keep their heels down. They just can't get there, like and so, you know, and maybe that's an anatomy thing, maybe their connective tissues just are so resistant and kind of whatever, thick or dense, and they just,
it could be an injury too, like a past injury
for sure.
You know, I've had that a lot of times, especially with the guys that are fighting. You know, because they'll kick elbows and everything else, and then their ankles are just trashed. Totally. You know, or even with the wrist, like with Maureen, she can't extend. She can't extend the wrist. I mean, I guess 90 is way out of the question. She can't do push-ups.
Totally.
Because she broke and fractured her entire wrist.
A lot of those joints are like that. Like wrists are like that. They can't get extension back. I mean, you see a ton of them. Like, you get the joint literally changes, whether it's, you know, scar tissue that forms that people just, and you have to get on it right away on those injuries. If you don't, then it just kind of forms like that, and people lose mobility. So that's, previous injuries are a huge one.
Well, let's talk about that real quick. So, like, let's say somebody gets an injury. Let's say, for instance, we'll go with the ACL tear, because that's kind of common, right? ACL tear. What are the major things that we look at? Because we don't do rice anymore. It's kind of out of the norm now, I guess. What's the primary focus that we need to focus on? In the beginning, and then obviously progression.
For sure. I mean, you will actually see a lot of surgeons still do ice. And those big surgeries, like, and I think that is being questioned more and more. Like,
is that more for pain?
Mostly pain, and I think they're trying to kind of keep the swelling response from getting too crazy, like too overblown.
Because too much swelling could cause pain.
It can, it can cause pain, and there's sometimes there's some thought that too much swelling can cause other damage to tissues just because there's too much swelling in there. But mostly, like, I think it's, you know, ice and heat do have research for pain control, but we've kind of moved away from that stuff. You know, RICE was rest, ice, compression, elevation, right? We don't really tell anyone to just straight up rest anymore. Usually it's some kind of active mobility thing. You know, there's a place for it. It's kind of like modified, like a little bit of rest, like right in that beginning phase. Ice is pretty much gone because they've shown that it delays the healing of soft tissue injuries. It slows immune system cells from getting in there and cleaning up the injured area, so which ultimately just slows like your return to sport and things like that. Compression and elevation are still in the new new models for rehab, but if you look at an ACL, and most injuries are like this, like in the beginning really you're looking at trying to get like pain and swelling and stuff like that under control, so that's probably going to be some kind of movements. It might be compression, elevation, like those are still useful things. And then after you get that, as you're trying to get that stuff controlled, next is mobility. Almost every injury is like that, like get mobility back, especially ACLs. You have to get knee extension back right away. You have to make sure the person has their knee, can get their knee straight. And then flexion slowly comes back as they heal, but that's kind of the next focus in most injury rehab is like mobility. And then after that, it's motor control, like sometimes we call it sensory motor control, because it's this whole loop, right? Like your sensors, you pick up on sensations, that goes into your brain, right? And then you have a motor response, and that's kind of motor control. So it's like, it sometimes looks like strength, like in the book I show some of these, like a lateral step down is one we use a lot, like where the person's on a box, one leg's kind of going off there. It looks like they're kind of doing like a partial single leg squat.
Oh, that sucked so bad when I was getting back into it.
But you know, I mean, it can be a strengthening exercise, but mostly we're doing it for movement control. You know, it's like a movement quality. I always say, like, you want to get mobility, then you want to work on movement quality, and then you want to start loading the system and getting strong. And I think that's probably where you and I like that movement quality. That's where you can start thinking about like biomechanics and posture and like setting them up as best you can. Because I mean, you want to have people in a good position if you're going to start putting load on them, which with athletes, usually you're putting load on them.
Yeah, definitely. You know what was the worst for me was stepping down off of a step where that knee was traveling over the toe.
Yeah, for sure. Yeah.
That was the worst because I felt it. It was like a patellar tendonitis or like it was super painful. Which
is like crazy, right? Because that ends up being kind of the exercise. Like we do those decline squats where you want, like patellar tendonitis is a good one where you want the knee to go past the toe in gradual doses to make it stronger.
Sure. Well, that was the goal. What I found was that when I put, like if I did the band around the back of my knee, like a TKA, the band for some reason, maybe traction, I don't know, but it maybe it was a tactile cue, but it allowed me to really go a little bit further. Almost because it had the compression effect.
Yeah, the band was hooked behind you.
It was pulling this way.
It was pulling forward.
Yes, it was assisting me.
Yeah, it was assisting.
And then when I extend, because I wanted to get the quad, quads engaged, I would extend and it would feel would feel good.
Yeah, it could have just been that cue. It's crazy how sometimes like a little band like that will get people to tap into like their vastus medialis. Like they'll I think it can help them. Maybe it improves that motor control a little bit. Like you can activate. Yeah, that's interesting. I thought for at first you were going to say the band was behind you, and maybe that was unloading. But going forward,
those Spanish squats too. That's what's called, right? Spanish squats.
Spanish squats.
Those were great. But I already had that. Like I already had strong hips. I'll tell you what happened. I atrophied a lot on my quads, like immediately. And they had the nerve block in there, and I was like, "What the hell just happened?" Like it was not even like I got off of it. It was weird. It didn't fire, and it immediately atrophied, which was strange to me. You know what I mean?
Yeah, it is kind of crazy. I mean, you see people atrophy super fast, and they like in the knee. This happens in lots of joints. It can happen in all the joints, but the knee is probably the best example where they call it arthrogenic inhibition, where basically arthrogenic means it's coming from your joint. Arthro is joint. So like if you have a joint injury, your brain, for whatever reason, I think because the quads are kind of the main stabilizer of the knee, your brain wants to take stress off of that injured joint, so it just shuts the quads off. It basically, the joint causes the quads to become inhibited, and then they atrophy so fast. I mean, almost everyone, literally everyone who has an ACL operation comes out with just their quads are gone.
Yeah, I took the brace off, and I was like, what the fuck? Yeah. But I was able to get it back fast, which was cool. And then, I think my major concern in the beginning was like I immediately started doing quad sets, just kind of squeezing and just trying to get that range, because I knew that extension, that was one of the main things. But what was really hard because of the scar tissue was the knee bend.
For sure.
And I was like driving it, doing those assisted sliders, those hand sliders.
With like a towel and stuff. Yep. That's hard with yours because you had a patellar tendon graft. That is hard. Like people get patellar tendinopathy, and then flexion is hard because you're pulling on that incision and all that scar tissue. That's, people don't always appreciate like. Your skin has to be able to slide and have mobility, and so a lot of times with scars we'll do that in PT, kind of like look at show people like your skin has to be able to slide over these structures, and when people have a scar, you can form adhesions. I've even had cases where people have had scars and I've worked on it, it would pop kind of like Rice Krispies, like, and all pop and break up, which is like
that's how it felt.
Yeah,
it felt like I was gonna pop through it.
Yep.
You know, and then I would do things to I would just sit in those positions. Like I would pull, like, you know how you like sit like back in karate or back in martial arts, we'd sit with our knees and we fall back. Like I was sitting and like one side would drop and it would just hang in there, and it was painful because it's pressure. But it popped one day and I was like, oh, this is amazing.
Totally. He break that stuff up.
Broke it up.
Yeah, the same thing happened to my knee when I had that contracture from that knee surgery. I was stuck and I went to climb through. I was in Montana, you know, and I was out at this buddy's trailer, like out in the woods, and I went to climb through a barbed wire fence, and my foot got caught because I couldn't bend my knee. And on the other side was a hill, and I fell on the hill, and while I was falling, it popped my knee, and I heard it crack. And I got up, and I had all my mobility back. Or the scar tissue was unbelievable.
That's one of the greatest things about getting injured is getting better.
Totally.
And you know what? It also is like you learn too as well. Like I learned a lot, you know, because I was like I always knew about it because I've been around it, you know. And I was like, all right, when you take something that could potentially in your mind be detrimental or heartbreaking or a loss, and you change your perspective, it allows you to cope with the situation and then learn and evolve. And that's what I aim to do, especially after this, and anything that I go through, anything that you know we've been through, challenge. You know. That's why I think that when we talk about pain from a psychological standpoint, it has a holistic approach. Like you have to have a holistic approach, and you have to understand that this pain is something that is going to make you stronger.
For sure.
You know?
Yeah, I think that part is probably one of the most exciting things I wanted to cover in the book, because we have a lot of research nowadays showing that, like, you know, the more you know about pain, the less kind of fearful and anxious you are about it. You know, so when people understand like what is pain, how does it work, it gives you, I think, to me, kind of like a protective armor. Like I think about, like, you've had an injury and you've had pain and you made it through it and you kind of understand it, so probably the next time something like that happens, you wouldn't freak out as much, you wouldn't be so worried. And I think to me that's like being a PT, and I feel grateful to know a lot about these different, to study kind of pain issues, because when some new pain happens on me, I don't think I would probably get as worried as the regular person, because I'll be like, oh, it's probably my rotator cuff tendon, it's probably just a little flared up. I did this thing yesterday, it probably just got a little irritated. And I think I really wanted to cover that. You know, the first 5 chapters are all on pain, and we have research now showing that if you just kind of help people understand pain in the beginning and you make it less threatening, that can actually make their pain less. So that was like a big part of the beginning of the book. And even like you said, you know, pain and injury are, you know, injury can be a great teacher, pain can be a great teacher. I think we talk about that in there, that trying to reframe it positively, because, you know, obviously it's a bummer to be injured and be hurt, but I think it teaches you more about your body, you learn about pain and injury, it helps better prepare you, because inevitably we're all going to have pains and injuries again in the future. And
for sure,
the more you learn about, I mean, to me, like, of all the things you can learn about in life, like learning about your body's one of the best you can learn about.
Absolutely, man. Well, here it is right here. Rehab Science, How to Overcome Pain and Heal from Injury. I highly recommend this book. You guys got to check it out. Doesn't matter who you are, athlete, general person, somebody who just likes to work out, this is going to help you. So, and also coaches and clinicians, make sure you check this out, because I know you guys are wondering what this has in it. I would say this is like a textbook, 100%, right? Where can they get this book at? So
it's all the major, you know, Amazon, Barnes & Noble, all that stuff like that. It's just Rehab Science, How to Overcome Pain and Heal from Injury. Dude, just thanks again so much for having me. I really, this book is like, I really do think it'll help people. I mean, besides just the pain and injury information, it's got all the programs with pictures of me doing the exercises. So I really wrote it to kind of have some of that kind of academic-y, write it in a way that like the regular person could understand pain and injury, but then they could also just have something to apply. Like go back, I've got tennis elbow, I can go back, see the exercises somebody would give, like a PT would give me, or like I've got this problem. So I really think the social media stuff's been helpful over the years, but this is so much, you know, you can't be that comprehensive on social media. And so I think this is gonna, it's just, there's way more nuance you can cover in a book. And I think, like you said, I've loved people saying that. It's kind of like an encyclopedia of injuries in a way, and the encyclopedia of injuries and pain.
Yeah, this is similar. This wrist flexor curl right here is similar to what we went through.
Exactly, we were just doing that.
Yep. Guys, check out the YouTube video. He went over some stuff for elbow tendonitis for our Miss Maureen Shea over on the YouTube channel. So make sure you check that out. Make sure you follow my man. What's the Instagram again?
Rehab Science.
Rehab Science, no underscore, nothing.
Just one word,
through, right? One word on Instagram and the YouTube channel too as well.
Same handle.
Nice. All right, check him out. Make sure that you do so. Subscribe and get this man a follow. You won't be disappointed. I guarantee that. All right.
Thanks, brother. Thanks, man.
All right.
Awesome to be here.
See you guys next time.